Hi, YouTube. We're back. I am Dr. Ray, and this is Dr. Pace-Newbern, back with another episode. Today, we are going to discuss the day in the life of an OB nurse. Dr. Pace-Newborn is a veteran OB nurse, and she's going to share with us some things related to the day in the life of an OB nurse. So, all of you out there who may be interested, stick around for this video because we have some great Q&A going on. But to start off, I'm going to give the floor to Dr. Pace-Newbern and let her introduce herself and tell you a little bit about her nursing career.
All right. So, hey, I am, as you said, Dr. Pace-Newbern, and I started my nursing career back in 2002 and graduated in 2004 in terms of nursing school. This is not my first love, psychology is. And as a result of realizing it wasn't going to pan out, I went to nursing school and finished in 2004. And OB nursing is definitely what I knew I wanted to do. I knew I wanted to do that as a relation to me having my second daughter who had to go to NICU. And when I was trying to make a decision as to what I was going to do when I realized psychology wasn't going to work, and I had my second child, that was an epiphany for me. Like, oh, okay, wait a minute now. This degree ain't gonna work over here. I'm having my second baby. She went to NICU. I think I could do something like this. And at that moment, that was in 2000. So at that moment, I said, okay, you know what? I might could do this, and I might go ahead and see about changing majors. That was the plan initially, but then I ended up not changing majors and just graduating and getting my BS in psychology, and then went ahead and went to nursing school immediately thereafter. So of course, because I went to nursing school, could not wait to the rotation of maternal child, and I did okay in the class. It was the one class in the whole program that almost took me out the program, was OB, but they knew I had a passion for it. They knew I loved it. They helped push me. My instructors did. And then fast forward, I graduated in 2004. And at this point in time, they were just beginning to let new grads go into specialties. It was at one point in time, you had to go into med surg first as a new grad. And so for me, I was excited because I did my preceptorship and OB, loved it, knew it came natural. It just came so natural. I didn't have a huge learning curve when it comes to, in terms of being an OB nurse. And so I got my job, started off with this HCA hospital, which anybody who knows what HCA is and what they are about, how that goes, but started off at HCA hospital. And I lasted a year. And then I went to another hospital and then a couple more. And then I found one that I could tolerate. And I have done OB nursing for the entire 16 years that I spent on the floor. I've been a nurse for 18 years, but I have spent a total 16 years on the floor as a floor nurse, bedside nurse, while I was working on my education to get my master's and my doctorate. Once I completed my doctorate in 2020, then I finished, or I stepped down from, I retired, as I always like to say, from bedside nursing because I had had enough. But OB nursing has always been a passion of mine. I loved it. I still love it. I love teaching it. I teach it now. So the ins and out of what OB nursing really is, and it's not what people think, or it is what people think, but it's moved away from that in time due to certain situations, but we'll hopefully expand on at some point. So that's the gist of my career. And now I teach it. I just say I teach it. I teach it at several institutions, and I love teaching it. I absolutely love teaching OB. Like, I take jobs for OB. I'll teach it even at a fraction of the cost. I love OB that much, so I love it.
Thank you so much. Very passionate. We can tell you still have a burning passion for that specialty. All right, so let's get right into the meat and potatoes of the discussion. So a lot of people want to know, who may be thinking about being an OB nurse or going into that specialty, what makes someone, or a nurse in particular, a good candidate for this specialty?
Oh, good one. So you have to have a holistic well, nursing is supposed to be about holistic approach anyway. We're supposed to provide holistic care in nursing in general. But this is truly a situation where you're kind of caring for the family. It is the patient, the baby, and the family. So the husband, boyfriend, other siblings, grandparents. That is the unit that we take care of. It's not just, who's her support system. We want to know who her support system is. And so you have to be someone who is able to be I guess customer service centered in the sense that you're going to be inclusive of the family, because it's not like, okay, get out. Now, if they're causing problems, that's something totally different. But if they're not causing problems, you want to invite dad in, you want to invite grandma in, or sister in, or siblings in, to be a part of it. And so you have to be someone who is people friendly, who can tolerate being around not just the patient, but addressing issues with the family. We deal with a lot of psychosocial issues. So not just your, do you smoke, do you drink, but your socioeconomic status a lot of times dictates, what you got going on in life. The people in poverty, and it's not just the rich and famous to get pregnant. It's almost anything but them. They get pregnant, they have one or two babies, where the rest of us is having babies left and right. So you have to be ready to deal with that. Keep in mind, it's all women. The patient population is all women, besides the babies they have, which could be boys. But outside of that, is all women, and their childbearing ages, believe it or not, from age 12-ish to late 40s, early 50s. As long as you're having a period, you can get pregnant. So we don't have to think of it that way. But so you think about what we call geriatrics of OB. You have a 45, 50-year-old mom, you're like, wow. So you have to have a mindset of like, okay, you know what, it's mom baby unit, whatever they got going on personally, you have to bring that into it. You do have to be a team player, and you're simply not going to have any males on the floor, male nurses. Now, there are males who definitely are into OB, but you're not going to see that as readily as you would ICU, ER, places like that. What else about what kind of nurse you need to be? Of course, caring, and that's kind of cliche, as nurses should be caring anyway, nurturing, as nurses should be that way anyway. But this is a specialty unit in which you really need to hone in on those skills, those soft skills of being caring and being compassionate. And I remember getting towards the end, getting burnt out when people were asking me questions, and I'm like, I didn't answer this question a million times. But the thing is, this is their first baby. So it is a relevant question to them. But for me, I'm kind of like, I didn't answer this 15,000 times already today, but they don't know. So I have to kind of sometimes pull back, or I had to pull back and say, okay, they're asking questions because they truly don't know. And then that's the other part. They truly don't know. Having a baby is I want to say, a once in a lifetime experience, because it happens often. But having a baby is a unique experience comparatively to coming in the hospital for, you had a heart attack, or your blood sugar is too high, or your blood pressure, your blood sugar or blood pressure is too high, or just other ailments when it comes to that. And speaking of that, OB is not pretty. We see on TV where you have moms coming in, and you see them, and they're pushing, and they immediately go to the scene at the end where the baby wrapped up and mom looking like she's pristine or whatever. It's very messy. A lot of body fluids. The baby is slick. She looked like a hot mess a lot of times. It's just not pretty at all. And nobody likes to talk about those things, how pretty it is not. She's tired. She's in pain. She's bleeding. She doesn't feel good. And then a lot of times we have body image issues. Okay. So when you were pregnant, you looked glowy, you're beautiful, you had this big round belly. Well, guess what you still have after you have the baby? You still have this big, it's smaller because the baby and the placenta is out, but you still have this big round belly. So then we have image issues, the mental aspect, the depression that people don't want to talk about. So it's not pretty like people think it is. And I think that's the biggest thing. If you can get past that it's not pretty, and you can take in the blood, the gore, the attitudes, the mental health component, and you're caring, compassionate, and I think you'll be good to go.
Excellent. That was a great rundown. I actually learned some things there. All right. Next, we have, how would you start your day as an OB nurse? Can you give us a little synopsis of how your day may start on a typical, not too crazy kind of day?
So we come in, change of shift was at 6:45 for us. And so I would come in and clock in, and I literally did not go to the floor until I clocked in first. I'm not saying that's always the best rule of thumb, but I was too lazy to walk from where the Chronos was to the floor and back, But I would walk in, we would get our patient assignments. The charge nurse would give the assignments. Sometimes I was charged and had to make the assignments. And after we get our assignments, we do bedside report. We do the initial report at the nurse's station, getting kind of the general rundown of the patient situation. And then after that, we would go to the patient's room, introduce the oncoming nurse, which would be me, and she's going to take care of you. And I'll say, hey, okay, I'll be back in about an hour and a half to start your assessments, vital signs, meds, water, stuff like that. And put my name on the whiteboard, change the date if need be. And then that would be that until I've met all 6 of my patients. Our ratio is was 1 to 6. So 1 nurse, 6 patients. And your acuities can be various, okay? And we didn't have techs on our floor. So when I say we did total care, we did total on our floor. We did total care. Now, total care don't mean the same things that mean in a nursing home or somewhere like that. Total care meant that I did my vital signs. I got my patients up. I cleaned them in terms of changing their pads when they could not do for themselves. C-sections cannot do for themselves initially. We did all that ourselves, empty Foleys and all that. We didn't have a tech, it was all on us. And then after I do that, breakfast was next. So I made sure that after I got that done, I went and got me some breakfast, and I would hit the floor probably about 7:30. So from 6:45 to 7:30, I would have had report, breakfast, or finishing up breakfast by then, or maybe I'm just getting back for breakfast by then. But either way, by 7:45-ish, I'm at the Pyxis, pulling all meds for my patients, usually it's Colace in the mornings and prenatal vitamins in the mornings. That's what they're all getting, unless they're all on, or somebody is on a specific medication like blood pressure or Synthroid, which I think night shift would give in the morning. But if not, we would give it first thing. And a few other things, antibiotics or whatever. But for the most part, everybody's getting Colace, and most people are getting a prenatal vitamin. And in addition to that, they will get a pain pill if they need it. So when I went and asked everybody, how are you doing? What do you need when I come back? They may told me they needed a pain pill. So I'll go ahead and add that to the mix. I said, can you wait till I do your assessment, or do you need it now? Of course, if they needed it, when we did bedside report, I go get it, or the night nurse would go get it. But either way, I do that. So for me, when I clustered my care, I did everything at one time, meaning I brought my pain pill, my Dynamap to take the vital signs, I brought the computer to scan the meds, and I got their water all at the same time. And I hit every single room and did everything I needed to do for them, including their assessments, all at the same time. So each room would take me about, say, 20 to 25 minutes, depending on what's going on with them. I would save my C-sections, either do the C-sections first or do them last, depending on what I found out during our initial bedside report. So if the bedside report seemed like they could wait towards the end, that's what I did. I know nursing school teaches something different because they're more critical typically, but they take the most time. So for me, if I can go ahead and nip the faster ones out, the other ones out the way, I'll get them nipped and then go and do the C-sections after the fact, or whatever I need to do. Of course, you change it as you go. After I did all that, it's now probably about, say, 9:30, 10 o'clock in the morning. I've did everything. I've seen everybody. I have given all my medications. Water pitchers are filled. It's time to chart for me. I don't chart. Our computers are not in the room, so we have to come back out to chart. So I would chart. Once I charted on everybody, it took me about an hour to an hour and a half to chart on everybody, because there's literally we had 10 slides per patient to chart on. So that assessment and everything else is 10 slides per patient. So it took me about an hour and a half, depending on what's going on with the patient, to chart. And let me go back for just a minute and say our floor was an antepartum, postpartum, and GYN floor. So we didn't just have moms. We had moms who were still pregnant. And we also had GYN surgery. So people who have female issues, hysterectomy, bladder prolapse, whatever happens to be, ectopic pregnancies, we did all that on our floor. And so it was a 24-bed unit that we had. So I took care of all those kind of patients. So they were not all moms. I want to make sure I say that. And we did not do couplet care. So that's something else that people tend to say, did y'all have couplet care? Because couplet care is the new thing. How we did things were the old way, where you had a postpartum floor and you had a nursery separate. Now it's couplet care when one nurse has a couplet. We didn't do that way. And I wouldn't have stayed if we did do it that way. So, all right, back to my day. So I've charted everything at this point in time. It's probably around 11 by now-ish. Now we appear bidding on who's going to lunch first, because the cafeteria is only open from 11 to 2. So we had to figure out who's going to lunch, at what point in time, and who's getting first, second, third admit. And so it's kind of based off of who's getting admissions, discharge, and things like that. Once we figure that schedule out, I either go to lunch or I'm continue to work. At this point in time, I'm now going to work on my discharges. So I've assessed everybody, I've medicated everybody, I've got all my morning meds done, they all have water, they're all safe, and they've all been documented, it is now time to work on my discharges. So now who's going home? And so now I'm up here literally at the computer printing up paperwork for everybody and printing up everybody's packets. Okay, do they have scripts on their chart? Pull the scripts, put that on their chart. And I come up with all these packets to make sure everybody's stuck together, then go boom, room to room to room to room, going to do discharge teaching for everybody. And we did the discharge teaching too. So and then I'll be finished with that by, say, depending on what's going on the floor, say by, and keep in mind lunch is somewhere in this process too. So by, say, 2-ish, maybe 3, I'm done with all that. But at this point in time, as I'm getting rid of people, I'm also getting new admissions. Okay, so then you have to go set up your own room. We don't have nobody help us. So I'm setting up my own room, getting ready for the next admission to come in while I'm discharging somebody else. And then at 2:00, it's time to do your midday meds and vital signs. Our vital signs were 10, 2, and 4. So I started everything at 1:00 because I had a lot of patients. So if I could, I started at 1:00. If not, it's gonna be on 2. And what I would have to do is, they have 2:00 Motrins that they get, sometimes colaces, sometimes nothing. I mean, I may not hit every room because I may not need to. Depends on the vital signs and what to do at that point in time. After that, it's just kind of maintaining them for the rest of the day. Going and doing we have to do hourly rounds during the day. So every hour, check on them, every 2 hours at night. As much as I had to do for these people, I may not have seen them every hour, but between me and nursery, they were seeing every hour because there's a nursery nurse and then there's me. You see what I'm saying? So I may have seen them, or or the nursery nurse has seen them just take care of the baby. So, and outside of all that, we're educating all day. So we're educating, making sure they know how to clean themselves, change your pads. When's the last time you changed your pad? Wipe from front to back. You'd be surprised how many people don't even know that they're supposed to wipe from front to back. Or you'd be surprised how many people that I have gotten up for the first time, and what sounds so dumb to me, but now I'm like, okay, well, if you don't know, you don't know, is like, they will sit there on the toilet they went to go pee already, and they're cleaning themselves up. And I'm like, what is you still wiping for? That's like, the bleeding won't stop. I said, this is like a period, it ain't gonna stop. They have this thought process that they wipe and it's going to be done. I'm like, no, this is like a period. It's going to go on until this process is over, this healing process is over. And they don't know that. So we spend a lot of time educating in OB as well about, how to take care of themselves, how to take care of baby. And of course, we're talking about birth control. Are you wanting to get pregnant again, or you shouldn't get pregnant again? So we try to make sure that people have, birth control plans in place, or if not, that they're gonna discuss it with the physician on their next visit to the doctor, usually within a week or 2. And let's see, 4:00. I had this rule that if you called out after 4:00, I'm getting my last assessment done and my vital signs done for 6:00. Our last said it was due at 6:00, but after 4, I'm like, okay, you call out. I'm about to go ahead and get your water pitcher done, your pain pill done. I'm about to get everything done, because at 6:45, it's time for the next shift to come in, and we do the same process over again in terms of doing bedside report and all the other stuff. I cannot stand where I didn't sit there and did all this stuff, and then 6:45 or 6, whatever time it is when the other shifts come in and we go bedside and they want a pain pill. I'm kind of like, okay, I was just in here. So I try to go ahead and nip that very early. They can't have it. By the time we do bedside, they can't have another pain pill, typically. That way I can get out. I can get out on time. So, and we had to be out by 7:08, I want to say. No, 7:08 was the earliest we could leave, I want to say. So, yeah, that's kind of how my day would go on a typical day. It's always busy. We have doctors that are coming in all times of the day and asking how their patients are doing. And, the phones are steadily ringing because you're getting doctors phone calls from L&D because they're trying to give you a patient. Phone calls from nursery because they're asking about a mom situation. Well, mom was positive for this drug, and do y'all have results on this, that, and the other yet? Because we don't see nothing in the computer. I'm like, well, you got the same computer system I got. So if you don't see nothing, it ain't there, or I'm calling them and asking them, hey, do y'all have a cord blood on baby yet? Did y'all draw that yet? Because I need to do that to know whether I need to give mom Rogam or not. So we have to really kind of bounce things off of one another. But at the end of the day, it's something I really love, but we have a lot of issues within OB nursing. And of course, the state of healthcare in general does not make OB nursing any easier. But that's pretty much a typical day.
Very nice. Thank you. I definitely learned a lot. So for all of you baby nurses out there, you thinking about OB, that's a typical day for you. And of course, I'm sure there are days where things probably go completely left, like in healthcare, period. So, okay. So our next question is, let's see. Is there any special training that you need outside of nursing school for OB? Is there any special certifications, any other extra credentials just besides like your CPR and things and your nursing license?
To come in, no, but they will send you to all the classes you need to go to. So if you're a new nurse, you don't have to come in with anything besides you having your license as a registered nurse, or LPN if they actually hire LPNs in OB at your facility. But once you get into it, you will have to have, some hospitals require you to have ACLS. At one point, we had to have ACLS. We have to have NRP, which is neonatal resuscitation program. So you have to have that.
You
have to have
NRP, NRP.
NRP, neonatal resuscitation program.
Okay.
And then a stable is another one that some hospitals make you have. Ours did not, but I've had stable before because I worked at hospitals that requires you to have that. And then if you work in labor delivery specifically, you have to have fetal monitoring training, fetal monitoring certifications and things like that. But as as a postpartum nurse, I didn't have to have that. But we all three areas had to have. So when I say all three or all four, I mean NICU, nursery, L&D, and postpartum all have to have BLS, NRP at the minimum. All areas have to have that. And then of course, once you got into other things, depending on your hospital, some people do stable and stuff like that. So it just depends. And of course, fetal monitoring training for those who needed it in L&D.
And you called it stable or stable?
STABLE, stable.
Okay, you mind telling us what that is? Because I surely don't know.
I can't remember tell you what it stands for. But basically well, think of it this way, stable. So let's say you come from a hospital, like a level 2 hospital, and there's certain level nurseries. Okay, level 2 nursery, they see babies we deliver babies up to like 32 weeks gestation, or not, when I say up to, as small as 32 weeks gestation. And so a level 2 level NICU is going to make sure that, okay, so what if the baby is 25 weeks? Well, see, we can't keep that baby. So here, that baby's going to go to Vanderbilt. But until Vanderbilt comes, because it's about an hour and 15-minute drive for Vanderbilt to come down and pick up the baby, we have to stabilize that baby. So we have to take the initial steps of resuscitation to keep baby stable. That's the best way to say it, until they come pick the baby up and take the baby to said hospital, like Vanderbilt, who has a higher level NICU. So it's basically resuscitation efforts. It's kind of like ACLS specifically for babies. They're at advanced level. This is beyond the point of you just trying to stimulate them to get them to, cry and things like that. They may be, having problems breathing. They may be only 2 pounds born. They don't have any brown fat, so they can't regulate their temperature. Their blood sugar is low. They may have a heart defect. They may have all these issues going on that we don't handle at our facility. So stable is really good for your smaller hospitals, especially community hospitals. Not that you don't need to know it at the bigger ones, but you already have people on hand typically at your bigger hospitals. This is for the small community hospitals to say, okay, until y'all come pick this baby up, we got to keep the baby alive until you get here. So the stable class, or even NRP, so some require both of them, but they kind of overlap in terms of what you do. They kind of overlap. But some hospitals require both, some require one or the other. So, but that's what basically we do. We keep the baby stable until said facility transport comes and picks up the baby, because it's usually going to go to and it doesn't always have to be because the baby was born early. Sometimes the baby is just born with a lot of medical issues. So you could have a full-term 40-week, 8-pound baby, but he or she is born with so many medical issues that it's still something above what we do on our facility. So we're going to have to send you to a specialty hospital or unit that takes care of babies that has those kind of needs. Same way as if you go to ICU, there's different kinds of ICUs, right? So you go to an ICU at your hospital, but no, this hospital, you need something more, even more standard than and more care, someone who brought better acuity care than what we provide. So you'll go to a specialized hospital, a specialized ICU unit. That's kind of what this is, where we'll get you stable, and then we'll send you to a hospital who has a better unit that's going to take care of your needs.
Okay, cool. Bringing back some OB memories from nursing school. I remember something like that. Okay, very good. All right, so we got that one. What is something that every OB nurse should know?
This piggybacks from what we were talking about at the very beginning about, to see if you're a candidate to work in this facility and work in this specialty, shall I say. The biggest thing you should know is it is not what people think, in the sense of it's not Mary and John who she a stay-at-home mom or plans to be a stay-at-home mom, and and he's some executive somewhere, and they have this baby, and they got a nanny at the house. They got family on both sides of support. There's plenty of money for whatever the baby needs that they can get. That's great, but that's not what it is anymore. Yeah, it's very much
I would say that's a fairy tale.
Yeah, but that's what people envision, or nursing students or people who they envision their own deliveries, whether that be good or bad, as what we go through. And there's stories from all in between. But I can tell you, when I first started as a OB nurse, the big thing back then, and we're talking about in 2004, was, oh, she's a single parent. I'm like, if that's the worst thing she got going on in her life, she's gonna be fine. Then it went to she has STIs or STDs. I'm like, okay, everybody got that. Next. Okay, it's like everybody, not literally everybody, but we are so not surprised. Like, okay, which one do she not got? Do they got all of them? Okay, let's treat her, keep it moving. Then AIDS was a big deal. Then we've moved into drugs. Drugs is still an issue today. Our same-sex couples, 2 males, 2 females. But now I think the biggest thing now that we're dealing with or tackling is drugs. Low SES, socioeconomic status, poverty. Now, not that those things didn't exist before, but the state that I live in 2019 ranked number 3 in the US for opioid addiction overdose crisis. So again, we have people here in our small rural counties, especially, where it is the meth mecca. It is the heroin mecca. We have people shooting up in the hospital and then getting arrested, and then having to, we have people who are losing babies. I have to call DCS often, probably about every shift. I was calling DCS or waiting on DCS to come up here to see if they're gonna be able to take their baby home, or you gonna take the baby and put it in, who's gonna have the baby. That's what's normal to me now. So when you come into OB, really come into it with the mindset of, oh, I thought this was gonna be happy. No. There's some happy moments, but we have caught people. And then this is another thing. Anything that happens at people's houses, they bring all that drama to the hospital. Yeah. So they don't even have any filter enough to say, okay, we're gonna leave our business our personal business at home. If they got drama going on, you best believe we gonna know all about the drama. The baby daddy issues, who's fighting, this person's cheating, and I mean, it's bad. And we as nurses get brought into the middle of it. I've had even one guy come up to me, this happened several times, but he walked up to me with his phone on Facebook, and he gonna sit there and say, you saw my baby, right? Does he look like this guy holding up his phone, or does he look like me? So that means right there, he's questioning paternity. And I had to say to him, I said, you know what? If you're questioning paternity, to get a paternity test. And that's exactly how I had to address that. So even to the point where they bring, like, they can't even, most of us know to keep that business amongst our family, and we'll take care of that outside the hospital, but they can't even do that. They can't even do that. They come in high on drugs. They come in having abruptions due to them being on cocaine. It's just one of those things where it's just bad, so it's not what people think it is. And I think that's the issue that I think people don't realize. They think it's just a happy spot where we are doing whatever, that people are happy and they have everything together. And, you sit there and see some of these people's families get torn apart at the hospital when they come and take a baby away. It's very sad. It's just very sad. And then people talk about the fetal deaths. So then you have the fetal demise, is what we call. And so that's when you have either a stillborn or babies, stillborn, or just something happens with baby passes. And it's devastating. So can you imagine the toll that takes on nurses? And so people will say, well, I couldn't be an OB because babies die. Well, so do adults. So we're not aware that babies die, but the issue is that we become, it never gets old, but at the same time, we become more aware of it, just how you are aware of, I couldn't work that. Well, I mean, to me, hospice would be the hardest thing to work because everybody there dies. That's the point. But in OB, it's not where everybody, we don't come in with that mindset, and they come in threes, death comes in threes. So it's kind of like we have hard shifts too. And so if you're coming up with the mindset that you think this is going to be an easy unit, that you think this is going to be something that's going to be happy all the time, something that we ain't crying at times, and we putting out fires because the family's acting up, and it could be a total mess sometimes. And you come home and you are mentally and physically exhausted, and to the point where I'm not coming back tomorrow, type of thing. But that's kind of how it is.
Okay. All right. Makes sense. Next question is, what are some unique conditions or circumstances around OB? So what are some common, from a clinical standpoint, issues that someone could expect to see on a typical day on an OB floor?
Mental health issues.
Okay.
We have a lot of people who, depression, bipolar, schizophrenia. I had a really psychotic patient once, actively psychotic, who saw horns coming off the baby's head. I said depression already, bipolar. But mental health. People don't think okay, you just had a baby, so it's okay that, it's okay that you're crying and weeping. You just had a baby. That's the excuse. It's way beyond and deeper than that. That these patients also have comorbidities. We usually think of OB patients to be relatively healthy. No, they're not. They're not relatively healthy necessarily. Some of them are, but again, thyroid issues, diabetes, hypertension, a combination of them. And then anything that you add to a pregnancy, it makes it that much harder. So when people say, oh, OB is really easy. No, when you do, if you think of it as a specialized med surge, because that's basically what it is, a specialized med surge with only females who happen to give birth. But giving birth is a natural process, but the disease processes that come along with it may not be. So everything that goes on with a normal patient is compounded when you add a baby to it, in terms of what medications we can give, because we can't give everything to everybody because they may be breastfeeding. We have to keep in mind when it comes to mental health, we'll just put them on some Wellbutrin, but put them on something like that. Well, they're breastfeeding, they can't have that. You see what I'm saying? Or sometimes we have to make a decision. Listen, their mental health is so bad, breastfeeding is not an option. You see what I'm saying? We're gonna have to go ahead and get you on the medication. This is a bottle fed baby today. So, and then the whole breast versus bottle debacle. Okay, are you breastfeeding or are you bottle feeding? And then you're bad, make you feel like you're a bad mom if you're not. And then drugs, which is really comes back down to a mental health issue, and then you have people who don't even have the things that they need to take care of their baby. So you okay, y'all had 9 months to prepare for this, and you have to have a car seat to go home. So if you don't have a car seat for your baby, you can't take the baby home. And you'd be surprised how many people come to the hospital. Now, when I tell you the best hair, lashes, and nails, but yet you don't buy the baby no car seat, that's a problem to us. It's one thing when you're poor and you don't have it, you truly don't have it, you're barely making it. So I think that, you have to think about poverty too. Again, most of us ain't living in Beverly Hills, where you want to have, you're going to have, or Scottsdale, Arizona, where you're going to have the upper echelon. We don't work in, and we do have a county here that's kind of like that, maybe not that same scale, but it's kind of like that. And because I've worked there for one shift and didn't like it, because they put their patients in a bubble, like their stuff didn't stink at all. It was totally day and night. I would rather work with the poor. That's how bad it was at that place. But that's the gist of it. You're going to have mental health. You're going to have poor people, teen pregnancies. You're going to have people who are mentally ill having babies. People don't think about that. Mentally, intellectually disabled having babies. You don't think about that. And and then every gamut in between. I see situations where like, dang, didn't I see that daddy here last week? I'm like, oh yeah, I did see him in last week because he had a baby with that woman last week and he had a baby with this woman this week.
Messy.
And I have to watch myself. I've seen cheating couples. I've seen where they have babies at the same time. He went back and forth between two rooms. And so I mean, the stories that play out in the hospital, you be like, this right here, this is better than TV. Until they start fighting, then you got to call security. It be that kind of drama. So you have to be prepared for that too. And I always say as nurses, especially in OB, this is probably true in most other specialties as well, that we have to be the chaplain, security, somebody's auntie, mama, big sister. We have to be the nurse. We have to be the advocate. We have to be their spiritual advisor. We have to sometimes, we have to be dietary, we respiratory, and this is true in most specialties, but we literally have to be it all for some of these patients. And then the one thing I will say if somebody's trying to come into OB is take off, if you are a mother, there's times where you have to take off your mama hat and you have to wear your nurse hat. And there's times where mama does not agree with nurse, like mama me does not agree with nurse me, but I have to do in my setting, I have to do nurse me, if that makes sense. As a mother, I couldn't do, I wouldn't want to do that type of thing. So those are some things to keep in mind too. Like sometimes I have an internal conflict between nurse me and mama me.
Okay, excellent. And last but certainly not least, for all of those who are considering this as a profession, one thing I always like to do is to provide some sort of resources. As we all know, technology has inundated us, as well as in the healthcare arena. What are some resources you would recommend? Maybe apps or other things like that if you're going into the specialty, kind of like something you can look up or have a quick reference for?
I would say, to be honest with you, make sure you know the standards of nursing. I mean, OB nursing specifically. So I wouldn't say about any apps. Oh, I will say language barriers. This is true in any specialty though. Make sure you can speak the, if you can't get a translator app or use your language line or whatever, talk to your patients. But I will say this, ACOG and A1 standards are what we go by when we go by our governing practices for how we do standardized nursing and obstetrics and gynecology. And when we do that, we physicians who follow those standards are going to follow standards. And that's the physicians that you want. You want to follow physicians who are following ACOG and A1 standards because that is considered to be the supreme of supreme. Just like when you have the American Pediatrics, or the American Critical Care, it's the same thing, but it's specifically for OB. Know what their standards are. That's my thing. Know what their standards are, because I can guarantee you hospitals, physicians will take shortcuts and do things that are unethical, not right. And you want to kind of govern your practice by those standards. So I'm always, of course, being research-based, being a doctorally prepared nurse. But even when I wasn't doctorally prepared at that point in time, just master prepared, even with the bachelor's degree, I knew, because it was instilled in us in nursing school, to follow those ACOG and A1 standards. No matter what hospital we went to, when they deviated from those standards, we're like, that's kind of how you know whether you're working at a good facility or not, at least your units, or working for good doctors or not. That's the biggest thing I'm going to say, is just make sure you go by those standards. And anything else that the hospital wants you to know regarding how to practice for your patient, they will send you to appropriate classes for. So like fetal monitoring and things like that. Or if you're interested in that, you tell your nurse manager, I'm interested in learning more about X, Y, and Z, and they can provide you some resources. But as a general rule, ACOG and A1 are your standards you want to follow. And so just learn those principles that they provide regarding, again, obstetrical and gynecological care.
Excellent. Thank you so much, Dr. Pace-Newbern. This was an excellent conversation. I learned so much myself. And do you have any closing words, tips, or advice for our listeners?
Well, just, if you happen to love or think you would be interested in OB nursing, for one, don't be afraid to go into it right out of school. If that's what you're wanting to do, I personally don't believe into the notion of going right into med surg and then transferring over. Every specialty will train you for their specialty. So, I would say do what you want to do. But definitely come into this specialty for the right reasons, and making sure that are going to do whatever you need to do to take care of your patients. And so If anybody has any questions, specific questions that we did not cover here, then please go ahead and feel free to ask me, about what questions we have regarding, obstetrics and gynecology or newborn nursery. I do it all. And that's one thing I do. We are cross-trained into different areas. So if you go to a good hospital, they're going to have you cross-trained into 2 areas. So for me, it's specifically postpartum and nursery, newborn nursery. In labor and delivery, they may have them cross-trained from labor and delivery and postpartum. Nursery is usually cross-trained from nursery to postpartum. So at any point in time, they want to make sure that we can work in at least 2 of the 3 areas. The more areas you can work in, the more marketable you are. And if I had any regrets, and I've always said this, I don't know if it is a regret, but I don't think the opportunity ever arose. The one thing I want to do is go and work in labor and delivery and be trained. So again, to be more marketable, to say I know all 3 areas. But I would want certain nurses training me is the issue, because I know once you know what's wrong, you don't want anybody training you. And that's the problem that we have, with this profession in general. So definitely, if you can, to be more marketable, definitely go and try to get trained at least 2 to 3 of those areas. But I think that's pretty much it.
Thank you so much. And again, for anyone watching or listening, if you have any questions, comments, concerns, please let us know in the comment section and we will get back to you. Also, if you have any ideas for future episodes, please let us know.
All right. Also follow us on our social media handles. We are on TikTok, same handle at Nursing Dynamics. And then we're also on Instagram. So definitely follow us in both places. Also, if you look up at the very top, we have a Amazon, like in the banner area, we have an Amazon icon, as well as an icon to, I want to say Instagram or TikTok, or maybe all 3. But Amazon for sure is up there. If you ever want to know what we think in terms of what is a great NCLEX book or what is a great whatever, we have what we call Nursing Essentials on there, where you can go to our Amazon storefront and you can kind of see the things that we have vetted to say these are great products that we recommend. Most of them I've either purchased myself or just know they're great products through just teaching. And those are great ways for you to go through and get things for your NCLEX, for your maybe you want to know a certain kind of watch to get, or a certain kind of whatever stethoscope to get. We have vetted these things. And so go to our storefront. We're not requiring that you do so. If you want to buy through the storefront, that's fine. But if not, that's fine too. We want to just go ahead and have a one-stop shop for you, where you all can go and find the things that we have deemed to be essential for nursing school, and other things that we happen to use on a personal basis, skincare, just all kinds of things, hair, all kinds of things that we have done or used in our own personal lives that have helped with whatever issues that we have. So definitely use those things. But until the next time, until the next video, you all take care. Bye-bye.